Welcome to the Special Operations Medical Association podcast series on prolonged field care. Any opinions contained in these podcasts are those of the authors alone and do not reflect U.S. Army, DoD, or U.S. government opinion or policy.
All right, in this episode, we're going to talk about nutrition. I would venture to say that this is the most highly misunderstood topic for prolonged field care that we've encountered up to this point. This is also a topic that has great potential to get you into some trouble in the prolonged field care setting that you won't be able to get yourself out of. So far, all discussion that I've heard about avoiding feeding in the pre-hospital environment has centered around prevention of aspiration. But I think people make this assumption that if you're going to be sitting on a patient for a long period of time and they're not going into surgery right away, that all of a sudden it's okay to feed them, and nothing could be further from the truth. The specialist that we're consulting for this podcast is Dr. Chris Burns. Chris is a trauma surgeon out of Boston, and he's also a critical care intensivist. So aside from all of Chris's combat experience, because Chris has been deployed to Afghanistan, worked in the CASH, but he's also deployed to other parts of the world in support of special operations missions as part of a really small surgical team. So Chris gets what it's like to be resource depleted in a far forward environment, and he understands what it's like to be out there with this big expectation on your shoulders that if something bad happens, you're going to be able to take care of somebody for 24, 48, 72 hours. So he's the guy that we want to talk to about this stuff. But the big reason we're talking to Chris is because he's a currently practicing general surgeon. So he actually puts in feeding tubes and he makes decisions as part of an ICU team on when it's appropriate to feed patients. So we are getting the information from the horse's mouth when we're talking to Chris. So Chris, are you ready to talk about nutrition?
This is something very near and dear to me.
All right. So, a lot of people out there, they've heard of this HITMAN acronym for prolonged field care, and the N in HITMAN is nutrition, and it's hydration, infection, and tubes, and it's supposed to guide you through these things that you're not normally thinking about in TC3 and PHTLS type stuff. So it's supposed to put you into this prolonged field care mode. But I think people kind of jump to conclusions when they hear the N in nutrition, and they're like, oh, I got to feed the patient. And I think we assume because we're trained to give an NG tube, we may not have been trained about why people get NG tubes and what they're really for. I think people just assume that's how you feed people.
So as far as nutrition goes, there is nobody would disagree that nutrition is important in the intensive care unit. And every day on rounds, if somebody's not being fed, we always bring up when can we start feeding them, and if we can't start feeding them today, why is that the case? During the acute resuscitation of somebody who's sick, someone that you're, thinking about intubating, or who has recently been intubated, it is usually these are patients who are not going to be fed. Somebody comes in septic, or some trauma patient comes in, and if you think they're going to need to be intubated, you certainly don't want to feed them, because now you're going to greatly increase the risk of aspiration. That's why, 8 hours before surgery, you're made NPO by the doctor, or if it's an outpatient procedure, at midnight the night before, you stop eating. Every trauma patient that gets intubated in the ED or the OR is deemed a full stomach, because we just assume that they've had food in their belly or alcohol or something in their abdomen, and then they get an RSI with somebody holding, someone who has experience holding crike, someone with, active suction canister right there, and somebody getting intubated. And even still, sometimes these patients aspirate. So it's rare that we're really talking about nutrition in the critical patient in the first 24 hours. In general, in a surgical patient, someone comes into me with a ruptured spleen from a car crash, or ruptured colon from diverticulitis, which is a trauma in and of itself, and then postoperatively they have an ileus, or a delayed gastrointestinal function. At the point where I start thinking I need to feed them by TPN, total parenteral nutrition, I usually start thinking about those feeds around day 7, and I try to predict whether I think they'll be eating anything meaningful or having any oral nutrition after about day 10. So I would say, in general, I'm pretty comfortable going 10 days without feeding somebody. Now, the advantages of early feeds are, number one, if you're feeding the stomach and some of the gut, then the theory is you're decreasing the risk of peptic ulcer disease. So if you don't have ranitidine or, pantoprazole or some kind of H2 blocker or PPI with you, tube feeds can decrease the risk of a stress ulcer. Another thing is when people get sick, if you're not giving their GI tract some kind of nutrition. Now, I didn't say their body, but if you're not giving their GI tract, and that's, say, 10 to 20 cc's an hour of some kind of enteral feeds, there could be risk of bacterial translocation, meaning bacteria from the gut can translocate through the gut barrier because of decreased integrity from the disease process, and then can make the patient bacteremic. So in general, we absolutely want to get patients fed as quickly as possible, but you've got to respond to how they are physiologically. The gut is a large organ. If you are going to demand that a large organ in their body is working, you need to make sure that the supply to that patient is appropriate. And shock, of course, is inadequate oxygen supply to the body. So if your patient is in shock, you don't want to feed the gut because now you're going to feed an organ and potentially make it ischemic. That demand ischemia is the same concept as when it snows outside and some 75-year-old who hasn't exercised in 2 years goes out and starts shoveling snow. There is a demand ischemia on the heart, and they have an MI and they drop dead. So if you're going to demand that the gut work and the body is showing signs of overall supply-demand mismatch or shock, you are putting that patient at risk for bowel ischemia and overall bowel necrosis, intestinal ischemia. That is not common, but that is definitely a risk of feeding a patient who's in shock. It is certainly uncommon, but the reason it's uncommon is because we're rarely feeding these patients.
Okay, so I understand that there are definitely complications to feeding patients, but what about the actual procedure of feeding patients? Is that a complicated thing? Is that as easy as putting an NG tube in and putting some nutrition down the NG tube and putting it in the gut? Or how does that whole thing shake out?
So first of all, when I think somebody can tolerate tube feeds, I don't just have a tube in their nose and I start feeding them. Okay. I've got a tube in their nose that's probably been confirmed by some kind of radiograph that it's actually in their stomach. And if I'm starting to feed them, independent of talking to the nutritionist and trying to get an idea of what their goal tube feed is, we start out at 10 or 20 cc's an hour, not a 20 cc push every hour, 20 cc's throughout the hour, every hour, and then check what we call gastric residuals, or after you are feeding this patient, then you take a 60 cc Toomey syringe and then suck everything out of the stomach and assess, okay, how much have you put in the last 6 hours and how much is actually coming out? And depending on how much you put in, how much comes out, that patient may not, despite the fact that you think they're ready for tube feeds, if they have any kind of gastroparesis or continuing ileus, they're not going to accept the tube feeds you're giving them. So if you're feeding their stomach and it's not going forward, all you're going to do is keep feeding the stomach until eventually they're going to aspirate. So it's important to understand, we're not just taking like a can of muscle milk and putting it through the NG tube and saying, okay, now the patient has enough nutrition for the next 4 hours. We're talking taking a 10 cc or 20 cc syringe and every 15 minutes giving them a quarter of that and reassessing in 6 hours, are they available and is their body ready to accept tube feeds? That alone can take 24, 48 hours.
So why do patients get NG tubes?
Usually when people get sick, they have slowing down of their GI system.
or what is in the medical vernacular called an ileus. So the first thing you want to do, when I think of an NG tube, I am decompressing the stomach, removing air, removing fluid, removing any particulate that may be in their stomach from a recent meal. That's all I think of. That's what a nasogastric tube is. 16, 18 French, nasogastric tube, decompress.
So that's not something you feed through.
You can feed through it. Any tube that goes from the nose into the stomach is an NG tube. The feeding tubes that we use in general, because we have the ability with near unlimited resources, is through a much smaller tube. When I hear NG tube, I think suction and decompress. It has nothing to do with feeds.
So at this point, what would you say would be the criteria for someone who can tolerate oral nutrition in the prolonged field care setting?
If your patient can talk to you coherently, has a near zero aspiration risk, and they are verbalizing to you that they are hungry, despite the fact that they lost some blood and have a tourniquet on them, you could probably feed them. If you have a patient who is in any kind of single or multi-organ system failure, that is not someone that I would recommend feeding. If you have a patient who is intubated or criked, I would absolutely recommend against feeding them.
All right. So can you talk just a little bit about the actual NG tube procedure and potential complications from that?
In general, placing a nasogastric tube is not very difficult. Like most things in medicine, most things are not very difficult. And the reason it takes so long to become a specialist isn't because most things are easy. It's because you're asked to do things when they are difficult. To fly an airplane straight in the middle of the day with all the instruments working is probably not very difficult. The reason flight school is 2 years is because you got to know how to learn an aircraft at night in bad weather when your instruments have failed. Many intubations, endotracheal intubations, are routine and easy. The placement of an NG tube is usually very easy. There are tricks used to help the tube go in the right place, because you're taking a tube and blindly passing it down the back of their throat. It should go into their esophagus. It sometimes coils up in the back of their throat. Sometimes it comes out their mouth. Sometimes it goes into their lung. I've placed more than I would like to admit numbers of tubes in somebody's lungs. For me, I just pull it back and then I replace it, and it's usually in their stomach. I either flex their head more or do a couple of tricks to get it down to their stomach. It's not the end of the world. What is potentially literally the end of the world is if you put an NG tube into someone's lung and start feeding them. This is all low percentage. But then what are you trying to fight against? You're trying to fight against bacterial translocation and future bacteremia. You're trying to prevent against stress ulcers. So the risk, I think, of bacteremia and the risk of an ulcer versus all the other potential risks of feeding your patient, to me, it seems like the risk-benefit ratio is removed if you just don't feed them. I think the most important aspect of it is they don't need that nutrition. There are some benefits of feeding, but they absolutely don't require it. It's really the 7 to 10 day mark that I, as a surgeon and an intensivist, start kind of worrying about nutrition.
Okay, so just to wrap this thing up, Chris, are there any nutritional concerns that we should have with the patient in the prolonged field care setting?
Far more important is remembering to give maintenance IV fluids to your patient, not IV boluses for blood pressure, urine output, and severe dehydration, but basic IV hydration for the required water needed for normal physiology of that patient. The concept of maintenance fluids, that is so much more important than the idea of active nutrition in a patient. So if you could just eliminate the N in Hitman for nutrition, and I wish you could somehow replace that with need for maintenance fluids, you have done such a greater service for your patient than you can appreciate.
Okay, so for maintenance fluids, I've heard the standard 125 an hour. Can you talk about where that comes from and why 125 an hour is the magic number?
The nice thing about 125 is, so 42 cc's an hour is 1 liter a day. 84 cc's an hour is 2 liters a day. 126 cc's an hour is 3 liters a day. So 125 is basically one bag every 8 hours. Just spread it out.
All right, so to recap, number one, trying to feed somebody in the prolonged field care setting is just not worth the risks of a misplaced NG tube or providing some kind of physiologic demand to the stomach that the patient just doesn't need. Secondly, hydration is infinitely more important in the prolonged field care setting than trying to feed the patient. Third is aspiration risk. Even if you're doing everything right, you still might have an aspiration risk, and that's just something we don't want to add into an already difficult patient scenario. We give NG tubes to decompress the stomach and to remove the contents in there so they don't place a physiologic demand on the rest of the body when the patient's really sick. We don't use NG tubes as feeding tubes. And lastly, patients go days without being fed in ICUs all over the country without a big issue. All right, looking forward to your feedback on this. Go to prolongedfieldcare.org. Check out the show notes that has the outline of the talk with the major talking points and why we're avoiding nutrition. And let us know what you think.